All right. So yeah, I don't know if you guys can all see that, but there should be the notice on there.
Yeah, we see it.
You do?
Yeah.
Okay. So again, hopefully everybody's paying attention. All right. So today we're going to just kind of do a familiarization and a run through of the essentially it's difficulty breathing, the updates to the protocol, which piggyback off of the state EMS Commission's guidelines for new allowable interventions for EMT basics. So not much for the medics today, except for, I will actually ask for some of your input as far as kind of what you want the crews to do to assist you and what you don't want them to do. And so forth. So let me try to get my PowerPoint back up here. You guys still see the PowerPoint screen down there as well?
Yeah.
Yes.
Is there a way to change the class, like how we see the classroom and you? Because right now the recording notice is across half your face.
Yeah, I saw that, so I'll ask them. I do know on my end, I hit dismiss. Do you guys have an option to dismiss that notice there somehow?
Yep. That did it.
Okay.
Yep.
All right.
Okay.
All right. So, all right. Now you've got my slideshow again, right?
Yes.
Yes, sir.
Okay. So yeah, the only thing I don't know. Oh, hey, look, I got one up here too. So yeah, we all have a dismiss button apparently where you can clear that blue band. So we are all learning together, and believe me, I've had Boyer in here repeatedly trying to get this dialed in, and we're getting better. Unfortunately, right now I'm the only one that knows how to use it because it changes every day. So I'll try to, once we actually get it nailed down, I'll get sort of a cheat sheet in place so that all of you will know how to initiate training, because where we used to just invite through this iPad to get streaming audio between the stations and output for teams, it doesn't work that way anymore. We actually unplugged the HDMI cable from up here to the system to make it work right, which makes no sense to me, but that's where we are. So anyway, moving forward, just give a brief scenario real quick. Engine and medic respond to a residence for shortness of breath. The medic is delayed. You're an EMT working on the engine, no medics there, and he says, sorry. Your patient is 45 years old, laying down, showing signs of respiratory distress, breathing 38 times a minute. They have a heart rate of 130, blood pressure of 160 over 110, and you also notice that their arms and legs appear to be swollen. So just with that description, what are some of the things that should catch your attention pretty quickly? Yeah, so their rapid breathing is going to be a concern, okay? That might just be some anxiety though, right? So we don't know yet how sick are they, but what are some of the other signs that are pretty immediate that gives you an idea of what might be going on? Yeah, your edema, the swelling in the legs and all that stuff is usually a pretty good indicator. And it's something I want to touch on just real briefly is, we're very fortunate that we have our own ambulance and we have a lot of medics, or not a lot, but we have medics on the shifts. We need to not be so medic dependent, however, right? I started in, I know Tommy did too, in areas where we used to wait a very long time for an ambulance with a medic to show up. So we need to be good at BLS interventions. The nice thing is now the state and our medical direction is allowing us to do a little bit more that is beneficial to the patients as opposed to holding their hand waiting for a medic to show up, right? So this is good, but we need to start implementing it. We need to start using some of these skills that we're allowed to use under the direction with our medics, say we need to start helping the EMTs do some of the things they're allowed to do or allowing them to do them so that they can get somewhat proficient in it, even though it might not happen that often. All right, so moving on. When you listen to their breath sounds, you hear intense rales. It sounds like they are drowning in their own lungs. And that's one of the things I've always struggled with personally is, rales and rhonchi. And wheezing is pretty simple. I think everybody can identify a wheeze pretty quickly. Crackles. But what is a rale? Like if I tell you, hey, he's got rales, what sound do you sort of envision in your mind to replicate that?
Hard, raspy. Percolating.
Purple.
What'd you say? Down at ones, I'm sorry, what'd you say?
Percolator.
Yeah, I said if you listen to GoPro video of scuba divers, that's kind of what I think of. You get that bubbling aquatic sound. Yeah, that's what I think. It's usually muffled a lot, but it's kind of that wet gurgling sound, like a coffee pot or something like that. So yeah, good. We're all on the same page. SpO2 is 84 on 100% oxygen. So what do we think's happening with this person? What are some options? Clearly we need to treat the patient, right, and monitor or anything else. But given the symptoms presented to us, what can we assume might be an issue with the patient that needs to be dealt with? What's that?
Excess liquid.
Yeah, they've got excess liquid in their lungs, and it can be from any, a few different things. But yeah, they've got fluid in their lungs, and they're not moving air efficiently. They're not transferring oxygen properly. All right, so 2 questions. What is your field diagnosis? And you've already said they got fluid in their lungs, right? So it might be CHF. It might be, who knows? I mean, so what are our treatment options? What were they before? Before this came out in March and the state allowed some new interventions for BLS, what would we do for this patient? Yeah, give them oxygen and hope that the medic gets there soon, right? Because there was nothing. Again, that's a bad situation here for us. It's a really bad situation in the back of Princess Lakes or out in, Peogue or Brown County or wherever the heck you were. So this is really, really good stuff that they're able to give some interventions like this now while they wait for ALS assistance. So yeah, but what can we do now? Clearly, because that's why we're here. But what do we have as an option now? Well,
CPAP.
Yeah, CPAP. If it's just an moving air issue, that liquid sound, and they're not breathing well, we can assist their ventilations and their breathing with the CPAP. Okay. Now, again, that is only available on the ambulance right now, so that's something that we need to look at as well. See if there's any intent to spread that around a little bit, but it's just something we need to be familiar with. So the old way again was just treating it with a bag. You want to try to force air in as best you can, hard squeeze on a bag valve mask, keeping a good open airway. But out with the old in with the new, we now have the CPAP capability to try to assist. Now, again, this is not a CPAP machine like some of us have seen or are accustomed to for sleep apnea type situations. It's just a pressure valve that allows that oxygen to come in through the mask system and be forced in. Everybody, I'm assuming, probably more so than me actually, is familiar with the CPAP, where it's at on the truck, setting it up. Like if somebody was to tell you to go get it, how to get it set up, ready to go. And if not, that's fine, but we need to get, especially you guys at twos, you don't have the ambulance here in the building. So when you're down there, run through it. Say, hey, show me where it's at. If you show up on the scene and ask for CPAP to be set up, what do you want me to do? And that needs to be done basically at a shift level. So I want you guys to work together on where it's at, who sets it up, how you want it set up, and all that kind of stuff. But make sure everyone's familiar with its location and all that good stuff. So when we're talking about the CPAP, the use of continuous, I'm sorry. Oh, okay. The use of continuous positive airway pressure, better known as CPAP for respiratory distress patients, like those with pulmonary edema from congestive heart failure, has greatly impacted patient care in a positive way. So again, over years of study, they've determined that, hey, this is very helpful, and but it's also not readily available because it was an ALS skill or even in the hospital setting only. So why is it that through all these different studies, what do you think was found to be the case that allowed it to be released as a BLS skill? What makes it okay?
There wasn't a lot of there wasn't contraindications or negative things that could happen as a result of using it either at the wrong time or inappropriately.
Right, and not to insult anyone, but they want to make sure that they don't give us anything where we can hurt somebody, right? So CPAP, pretty low chance of hurting somebody with it. There are, like you said, not many contraindications. The risk to benefit for the patient is extremely high on the positive side. I remember years ago when we were with Nineveh, we tried to just get clearance for doing glucometer checks because we would have a diabetic, known diabetic, and again in the back of Princess Lakes, we're waiting on a rural metro truck from 65 and County Line, and we couldn't even get a glucose check on the patient to verify that the issue is what we thought it was because it was an ALS skill. We got the hospital to approve us to do it as a BLS, and then the state EMS commission shot that down and revoked it quickly. So those types of things where I can own my own CPAP machine, but you have to have a special license to use it on somebody who really needs it. Doesn't make sense. Anybody can go to CVS and buy a glucometer, but I can't utilize one in a pre-hospital emergency setting to check somebody's blood sugar, or I couldn't in the past. So over some time, they did some tests and they figured, hey, it really can't hurt people, but it sure can help them. So here we are with this opportunity now. So starting in March with the new protocols for the CPAP that is involved in the EMT scope of practice. And again, normally protocols are released in January, but they waited so that it would coincide with the state release of new skills from the EMS Commission. And that's why it went through March. I'm assuming at this point, everyone has done their protocol test. And if you haven't, we need to be sure and get one of those on file. Okay. Not something they're going to look very thoroughly at, but we do need to keep ourselves covered by doing that. So the EMR scope was updated as well, and that's just emergency medical responders, the old first responder certification. EMTBs, they added CPAP, end-tidal CO2, nebulizer treatments, which we'll talk about today as well, and Epi 1 to 1000. We'll talk about those a little bit later. But in the advanced stage, they have all the above, plus analgesics, Toradol for pain, and 4-lead EKGs. And I think this is the third day now, but I think I can confirm that we don't have any certified or practicing advanced EMTs anymore, right? You don't have that. Lynn, we don't have anybody who's under that, correct?
We do not.
Okay, and then as it says here, info on the advanced class to come, the info is it's not coming, okay? So that's it. It was discussed. There were some ideas thrown around. We thought we were getting close to pulling it off, and then it just kind of died. I would hope that maybe when all of this COVID stuff settles down, we can revisit it, because I do think that we have the instructors, we have the instructors, we have the field sites and everything lined up. I think that it would be very beneficial for us as a department to get people certified as advanced if we can. But the way it was going to be done through the hospital, I just don't think was going to be feasible. And it ended up having very low interest as a result. So we don't have any right now. So this is, everybody is either advanced or basic, or I'm sorry, ALS, paramedic, or basic. Okay. All right, so how the CPAP works, right? The constriction or compromise can be due to asthma, pulmonary edema, CHF, or even emphysema, chronic obstructive pulmonary disease. The exchange of carbon dioxide is restricted in the lower levels of the alveoli. So again, just to shorten this up, that transfer from the carbon dioxide to oxygen at the alveolar level is done because of the surfactant is there to pull the fluid away and allow the oxygen exchange. So when the body becomes overrun, the lungs specifically overrun with fluid, it basically overpowers the surfactant and makes it unable to make the transfer down at that alveolar level. So this now forces the air through, whereas it can't just make the natural transfer through respiration. Okay. Excess fluid from the heart failure will disturb the balance. All right, that's basically what I said. I just said it a lot dumber. Okay. So CPAP forces a small amount of air pressure through the pulmonary tree and into the alveoli, causing them to reopen. So just like it sounds, we are forcing the oxygen in to blow those little balloons open and close them back up because our natural respiration is not doing it. Additionally, it increases intrathoracic pressure, which will reduce the patient's hypertensive state, allowing the fluid shift to occur more easily. So it does have a reciprocating effect of the blood pressure generally will lower. Pressure created by CPAP is held constant throughout the breathing cycle, and the patient will feel a small amount of back pressure during the exhalation phase. Okay. When we talk about pitfalls, there's really not very many, but again, I find it interesting that the one thing they actually list is the main pitfall for CPAP in the pre-hospital setting is hesitation in using it, right? People are like, oh, I don't know, is this something I want to try? There's really very little risk in doing it. So if you think it can help the patient, if you hear these sounds and they're having difficulty breathing and their oxygenation, their SpO2 rates aren't doing very well, then it would be worth trying. So some parts of the system, pretty simple, really. You guys know this. We've got the mask as the harness system. Without a proper seal on the mask, the entire procedure is wasted. How can we tell if we have a good seal or not?
There won't be any air leaking out from around it.
Yeah, if we've got a good seal on the face, similar to if we were doing the old bag valve mask, right? If you hold it down tight, air, you squeeze the bag and nothing came out, you had a good seal. Same thing here. If it's pressurized and pushing the oxygen and I don't get any bypass or sound or anything like that, then I'm probably in good shape. Okay. Most common mistake is an ill-fitted seal on the patient's face, and it must be snug and have an airtight seal. What are some things that may cause us to have a poor seal on these masks? And even to the point where we may go, it's just not going to work. I can't get a seal. Yeah, if there are people with no chins, you've got some odd shaped or sized faces, right? I mean, sometimes it just won't work. Okay, what else?
Diaphragmatic.
All right, really sweaty. Yeah, we can't. They're really sweaty. They're wet. Can't keep them dry. It's sealing. You got, it's blowing by around there because I can't get a seal. What else?
Facial hair.
Yeah, the Duck Dynasty guys, or whatever. You got all these big, thick beards. You might not be able to seat it down there. We're not going to shave somebody to get a seal on a CPAP. So there are instances where even if it would be beneficial, if you can't get the seal, it's not going to work. It's a pressurized system, and without that pressure, it's just a waste of time. So just keep that in mind. We need to do our best to try to get it sealed. We've got the trunk with the PEEP valve attached to the light fitting mask to deliver the continuous positive pressure. And I think so far, if I'm understanding it correctly, we do have inline valves within the system now as far as COVID issues that we want to address that are supposed to try to reduce exhalation, vapor, and contamination. Is that right, Lynn?
Yes, there's a HEPA filter.
Okay, it does have a HEPA filter. Now, what can we do in addition to that, or what should we and probably are we doing in addition to that HEPA filter to protect ourselves in the event that our CPAP patient is maybe COVID positive? Yeah, just wear your PPE. And I don't want to, again, I'm hoping not to contradict anything that's being said out there or downplay anything, but I really hate the thought of us, not properly treating a patient because they might have this disease or something, or, distancing ourselves so much from a patient that needs our help that we can't help them because we're afraid of what might be going on when we should treat what is going on. Okay, so that's just my 2 cents on that. But yeah, wear your proper PPE. This has a valve in place to try to help and protect us. And, that's really all we can do is that, as in addition to, post-run decon, clean the truck, wash your hands, change your clothes, all that stuff. So do everything you can, but we need to still treat people. All right. So you also have an O2 tank with high pressure port connected to either onboard or portable. Make sure you have a working high pressure port on the oxygen regulator. And so again, yesterday they said if you're in the ambulance and they have you hook it up to the onboard, you have to remove the Christmas tree and thread the valve directly into the threaded port. So that's going to give you the high pressure on the onboard oxygen on the medic. So again, just please be familiar with those things. Yeah.
On the portable oxygen tanks, did we ever figure out how long those could last?
I do not know. Lynn, you got anything on that? What's the duration for a portable tank on CPAP?
So it's an on-demand system. So it's continuous oxygen, but it's only going to give them as much as they need. So most people probably about 10 minutes.
Okay. All right, so that's a good point that hasn't been brought up yet. If for whatever reason we're delaying the transport while we're administering this care, then we need to be thinking about spare bottles and having more coming in or ready to go to switch out. Okay, so that's a good point.
And that's good for us up here because we have the one and then a spare.
And now, Lynn, are there any plans, Lynn, that you're aware of, or is there any solid good reasoning for it? Are we looking at putting any CPAP equipment, masks and valves on the engines, or are we just going to keep them on the medics only?
I think we should have them on the engines. I think because we respond together, I think it's just a good continuity of care.
Okay, well, I mean, again, that's sort of out of my normal range of things that I deal with, but we've talked about it, and I think that one of the main benefits of this being a BLS skill is that it can be done, like I said, while you guys are already out on a call, while we're waiting on whoever, if we're going into Morgan County now, or, whatever. There's a lot of instances where I agree that they should probably go on both engines, but maybe at a minimum up here where we don't have the medic in the close proximity and now have the extended response area going over to sort of the unknown. So something we should probably talk to Chief Pruitt about moving forward. But and it's not really a cost issue, right? Is it? I don't know. That they seem to be.
No, I mean it's required by the state, so we're going to do it. So I'm not worried. So much worried about that.
That's a 213. Okay. All right. So yeah, who needs this, right? Patients with persistent dyspnea and hypoxemia. Patients with a history consistent with heart failure, volume overload, COPD, or asthma exacerbation that fit into this criteria. So our protocol for CPAP is adult only. We don't have a protocol or anything at this time for pediatrics. If we have a large child, for whatever reason, that maybe presents with a condition that you might think CPAP would be beneficial, what can we do? Call. Well, I wouldn't do, don't just put it on them, please. That's not the answer. Call the hospital. We are fortunate that we work in such close proximity and have a good relationship with our medical director that, I don't want to speak for Dr. Calls, but you probably got to do something pretty negligent and stupid to get him, sort of on your back on you hard. where if you say, you call him up and go, hey, this is what I got going on, you know, I know he's not 18, but I think he's a really good CPAP candidate. He's probably gonna say, yeah, go ahead, slap it on there, because it's also not gonna be a high risk for that person. But just keep in mind that it is, our per protocol, it's 18 and over. Has the ability to maintain and protect an open airway. You can't put a CPAP on an unconscious person who can't hold their head up, right? That's not how it works. So they need to be able to maintain their own airway. Systolic blood pressure at or above 90. Pulse oximetry less than 92 on 100% oxygen. And then severe or sudden onset of shortness of breath. Respiratory rate of less than 20, I'm sorry, greater than 25. Use of accessory muscles. What does that look like? Somebody's using accessory muscles. If I tell you that, what do you see?
Belly breathing.
Yeah, they're belly breathing. Maybe a lot of times you'll find them sitting on the edge of a bed, right? Hands on the knees, pulling in, nostrils are flared up. You'll see their collarbones and stuff all really just sucking in, flaring out. They are working extremely hard just to breathe normally.
Tripoding.
Okay, yeah, tripod position. So I've seen some difficulty breathings where you're like, yeah, this is really bad. And to add to that, I'm fortunate I've only seen it once, but I watched a person with severe difficulty breathing once say, hey, I am dying. I am going to die. Gentleman in his 30s probably, and somebody with us was like, man, shut up. You're not going to die. Stop overreacting. And by the time we put him on the cot and got to the front yard of the ambulance, he went asystole and died. So something to recognize is that feeling of impending doom, or people who have lingering and long-term history of difficulty breathing, listen to them, right? They can tell you if this is their normal level of difficulty breathing or it's worse than I've ever had, new. So yeah, listen to the patient and don't downplay. Now, will we encounter people who are over dramatizing their condition? Probably, but we don't need to tell them that. Just do your best to work within what they're telling you. So dyspnea at rest, right? Doing absolutely nothing, still struggling to breathe. And then your rales and wheezes. It can be considered in a flailed chest after contacting medical control. And again, we definitely want to contact medical control because pressurized air introduction into the body doesn't sound like something really great for a person with a flailed chest, but if it helps them, it helps them. So the contraindications, all right, respiratory or cardiac arrest, not really a thing for us. You don't want to use this in that situation. Agonal respirations. Suspected or confirmed pneumothorax or penetrating chest trauma. Because what did we say we need for this system to work? We have to have a sealed system, right? Any hole in the body is no longer a sealed system. And we talked about it yesterday. It's like, well, what if you sealed it up? I'm telling you, if you have a gunshot wound or a stabbing or any kind of penetrating trauma, we're past the CPAP on difficulty breathing issues. I don't think we're going to, throw a cellophane over a sucking chest wound and then CPAP them to help their breathing. Okay. So it's really two different things. Inability to maintain a patent airway. Again, if they're unconscious, bobblehead, they can't do it, then they're not going to be a good candidate for this. Tracheostomy. You're going to look really dumb if you CPAP somebody with a hole in their throat and a stoma, because it's just going to be like right there, coming right back out. Okay. It's never going to do what you need it to do. Okay.
Hey, Grammy,
Yes.
while we're on this, 15 is the age cutoff.
Is it 15?
It's 15.
Yeah. This is Tony Logan's PowerPoint, or not Logan, sorry, Lounger. So thank you for that. But yeah, he has it as 18. So now we know.
Okay, yep, 15.
Okay,
And
that's good.
Probably more size dependent than anything for tidal volume.
Okay. Well, good. I'm glad that you told me that because, yeah, nobody's caught that in the past 2 days. I'm just going off. He sent me this in lieu of audit review. So,
All right, the disclaimer is Lynn and Katrina caught it. I just told you about it. So.
oh, look at the brain on those two. Okay, cool. Thank you.
That's why they're on the medic.
Yeah, that's why they're on the medic.
Thank you. Let's give it up. Thank you for your service.
Yeah, so.
Get these people, Jeff, you better be clapping.
That way we don't have to keep saying it. So, okay. I shouldn't have taken it down when I was thanking Sean Campbell the other day. All right. Yeah, agonal respirations, also not a candidate. All right. Suspected or confirmed pneumothorax, chest trauma, inability to maintain the airway, any impediment to proper mask placement or seal, facial trauma, stroke, anomalies, or epitaxis. Garrett Wood, what is epitaxis?
Nosebleed.
Man, good job, you. Okay, right. Because the last thing we want to do when we are trying to deal with somebody who has fluid in their lungs is force, pressurized air with fluid like nosebleeds or not, or vomiting or anything else like that into the lungs. So anything in the airway is going to be a no-go. All right. Upper GI bleed, nausea or vomiting, inability to comply with the device due to severe anxiety or altered mental status. You are not going to benefit somebody's breathing if you are fighting them to keep a mask on them, okay? Not the way that it works. Now, that is something I want to make a point of is no matter what we're doing and what patients we have, if we are as calm as we can be and, friendly and give them good explanations of what we're doing, I think it's going to greatly benefit not only them, but us as we're trying to treat them. So I'm not, really known as a hand patter or anything, but what I can tell you is if I'm going on a difficulty breathing patient and I'm going to have to put this giant, trunk mask harness system on them, I'm not going to slap it on and hope that they're okay with it, right? So what I want to do is, all right, sir, here's what we have. We've checked your vitals. You having some difficulty breathing, understand? And first of all, what would you ask them about CPAP?
Have you ever had it before?
Yeah, have you ever had a CPAP treatment before? There's a chance they live in one or whatever, so it may be nothing to them, right? Maybe we're in a out of home environment. They have an onset of the difficulty breathing at the store or something, but normally, yeah, I get CPAP all the time. But anyway, say, here's what I need to do. I've got a CPAP mask. I'm going to put the mask on you. You're going to feel some pressure. It's going to help you breathe, so forth. But give them a good explanation, not of what you've done, but what you're about to do. Walk them through it. Explain to them what they might encounter. Say, hey, if this becomes too much, let me know, because you just don't want them ripping it off. But if you can put them a little bit at ease as you do things, very similar to, auto extrication. Before we start cutting on cars, we really preach, hey, explain to the patient what's happening. Well, you're going to hear a bunch of noise. You're going to feel the door move and this, that, and the other. No different for this situation. Make sure they know what's happening. But the last thing you want to do is like, look, you need this, just go for it, take it. That's not how things work. So again, explain the procedure to the patient, reassure them. To aid in this, explain, what CPAP will do. We don't need to break it down to the scientific level. Just let them know this is going to force air into your lungs and help you breathe a little bit easier. It's going to take some of the work off of your body to breathe. Have the mask on prior to putting it to the patient's face. You want to have them hear the sound so they can understand. Say, this is what it's going to sound like. You're going to feel it. Place the mask against their face with your hand prior to setting the strap. So get a good tight seal. Say, okay, you all right with that? I had to make sure this seals up. I'm going to pull this harness over and tighten it up so that it stays on your face. Okay, just be sure that they know what's happening as you go. Encourage the patient to breathe deeply. Now, if they could breathe deeply and comfortably on their own, they wouldn't have called you. But this is where we just, when they call 911 and we show up, they assume things are going to get better. So try to start making that a reality for them and explain what's happening. Try to comfort and calm them down, but coach them through their breathing. Secure the mask to the face with the straps, check for leaks, contact the receiving hospital. Why do we want to do that? What are some reasons we want to let the hospital know that we have a CPAP patient?
So they can get hold of respiratory.
Yeah, they might want to have respiratory already waiting in the ER for you, and they might put them on a machine, or whatever, but they can get all of that ready. Monitor and document vitals every 5 minutes, including SpO2 and end-tidal CO2 if possible. And this is really important. When we're talking about vitals, we need to get vitals immediately during our assessment, right? The patient assessment and that baseline vitals is probably the most important thing we can do right out of the gate. And what does that information, especially the SpO2 reading, do for us moving forward through the duration of the call?
Trends.
Yeah, it shows whether what I'm doing is helping or not, right? So don't forget the SpO2 reading when we're getting our vitals. Get all of your vitals, recheck them as often as possible, but this gives everybody an opportunity to see if it's giving them the positive impact that we had hoped, okay? Monitor and document. Watch for decreases in respiratory rate and mental status. Don't just set it and forget it on the CPAP, right? It's maybe not the fix. You put it on, they're not getting better, you might have to do something else, okay? So what do you do if you set it up, everything's perfect, everything's fine, you explain it to them, they accept it, but 8 minutes into the treatment, they suddenly stop responding, they slump over and more or less stop breathing. What do we do? Yeah, there's a whole different set of circumstances now. Treat the patient, right? Be like, I don't know, CPAP's still on, I don't know what the problem is. Right. So start to treat the patient. For now, we're not doing a difficulty breathing call, right? This is now a respiratory arrest or whatever. Okay. Control the airway. Make sure it's opened up. All right. So some end notes on the CPAP. CPAP is a great tool for keeping the airway open and supporting it by use of non-invasive procedures. It keeps people from having to be intubated. And why is that a good thing? I mean, a lot of reasons, but what do you think? What are some risks in innovation?
Getting off of the ventilator.
Right. Well, for one, you could damage the airway, right? There's always the chance of breaking, chipping, damaging teeth during the process. But right, if I can get them manageable on a CPAP, they may stay on a CPAP, get treated and released from the hospital far sooner than if they get intubated and have to go on a ventilator. All right. And don't hesitate to use it when you deem it necessary, and be mindful of the stress and anxiety. I really want to emphasize that point, that this is something that you can really make or break the situation for the patient and yourself if you just try to stay calm and relax and explain to them what's going on. All right, so any questions about CPAP, where it's at, how we use it, when to use it? Okay, again, maybe Lynn and I can work together to try to get, a couple more at least, I think, on this engine, but you might as well mirror everything. But it is something that is now in your toolbox as an EMT basic that can have great benefit for somebody who needs it, and pretty low risk in utilizing it. Similar to albuterol, which we'll talk about now. So new for 2020, EMTs will be allowed to administer albuterol. And this, I think the next photo makes this all worth it. Yeah. So indications for it are wheezes, lower airway obstruction caused by asthma or COPD, and then I guess bold red wheezing. I'm not sure why it's on there twice, but what do you guys, medics, don't say anything yet, but what do you see in this photo that is not right?
Doing it.
You want to?
Yeah, that's not albuterol, right? So that's not the albuterol 2.5 that we're supposed to be using. So this is not what we're looking for. So when you go to get your albuterol, be sure you read the labels, check it to make sure it's what you are supposed to be giving to the patient. But that came from the hospital. This is their program, not mine. But anyway, mechanism of action for albuterol, in short, it's a bronchodilator. It just opens up those constricted alveoli and everything within the lungs that is not moving air properly. And it doesn't matter what's causing it. If they're constricted from whatever reason, this will assist in relaxing that and dilating it. So on dosing, we can administer 2.5 milligrams nebulized at a flow sufficient to produce mist. Usually that 6 liters is perfect. Now we do want to, especially in today's environment, we want to try to reduce any excess vapor loss or escape around the mask, right? For one, if that's happening, the medication isn't getting in. Secondly, that's just additional contamination possibility. So, Lynn, is it okay to say that if we dial it up just until you start getting that fog, and let's just say for whatever reason, that's 4 liters, is that adequate if they're responding?
As long as they're responding to the treatment, I don't think that's an issue. We also now carry the on-demand nebulizers.
Yeah,
So
that's what we need. Is that a Venturi thing or something, Anthony said, right?
Yeah.
Okay. So yeah, that's a little bit different now too. So be sure you're familiar with that, but it's on the inhalation. There's a Venturi fan that basically vaporizes instead of that constant flow. So we can just make sure you're familiar with what we have. Instruct the patient to take slow, deep breaths again. And this is again where I would say, hey, I'm going to put this mask on you, administer a little bit of medicine. As best you can, take a good deep breath, try to hold it for a second so that that medicine can work, and then breathe out. So you want to, again, try to coach them through that. Observe the patient and monitor respirations. Make sure the treatment is completely nebulized. If you see that it stops fogging, then you might need to, sort of tap that container there at the bottom of the bowl or whatever, or I'm not sure on the Venturi system. I'm not real familiar with it, but there's sometimes just a minor adjustment in position will get that going again. So check that. Don't, smack the patient around or anything. Just make the adjustments on the device. If in 5 minutes after the albuterol 2.5 was administered, the patient is still markedly short of breath, then repeat with another 2.5 up to a total of 2. So for BLS, the protocol is we can go up to 2 doses of 2.5. All right. And you'll probably not have any real contraindication or any kind of bad reaction to that. The adverse side effects, however, are nervousness, restlessness, headaches, tachycardia, hypertension, chest pain, and palpitations. All 3 of my kids have been on albuterol treatments over the years, and I have my own machine back, because when we did that, we were doing so much of it. But the one side effect I recognize with kids is just it makes them very wiry. So you'll have similar effects on adults, but probably not to the same level. But for smaller kids, this stuff, I hated when they would start having trouble and I had to give them a treatment at like 9 at night or something, because they were going to be up for a while. It gets them real wiry. So that's the only thing. It can get them a little bit hopped up. Probably not as bad for adults, but definitely kids. So on the difficulty breathing protocol that was, came in March, we are working under it now. It covered the bronchospasms, asthma, COPD, and wheezing. Begin your medical care. And when we begin medical care, what's step one? We can get past the BSIC and safe stuff, but what's step one? What's that?
Their complaint.
Yeah, well, assessment and vitals, right? We need to just be sure we're starting with, hey, what's going on today? And if they can't start to speak to you, probably, you're probably going to at least get the baseline of a difficulty breathing call or whatever the case is. But we need to get really good vitals and a good assessment before we start doing anything, okay? If the patient is so short of breath that he or she cannot complete sentences, determine if there has their own prescribed inhaler, because you can still assist them with their own inhaler and administer the albuterol afterwards if it doesn't give them the relief. But if they have their own inhaler, start with that. For one, doesn't use up our supplies. For two, probably it'll help them. And there's a good chance that none of us are going to introduce anybody to albuterol or breathing treatments, right? If they're calling, more or less, they usually have a history of this. But they might have already tried their inhaler. That's one of the first questions you should ask is, do you have an inhaler and have you used it? If so, how long ago? And then check it for them. I know sometimes they still sound as if they have a discharge and there's not anything coming out or not enough. So it might just be a low inhaler or an empty one. So ask about that before you start this, but we can still do our own albuterol treatment on top of their inhaler. Observe patient, monitor response, make sure treatment is completely nebulized. All this is just a repeat of what we said earlier. So if we do all this, and again, for whatever reason, they gave me the presentation and it's backwards from what they're stating here, but if the nebulizer treatments don't work, you can move on to the CPAP. All right, we can try that. They did it the other way around in the presentation. The only thing I did call Tony to clarify is, he said, and I didn't look in our protocol book yet to see, and Lynn, maybe right off the top of your head, but we do not, for children, we can give the albuterol, we just don't give the second dose is what he said. It's a straight 2.5, and if that doesn't do it, then you just kind of go. But we can administer this to pediatrics as well for the same situation, just one dose only. Do you know any more on that, Lynn?
I believe that's how the protocol is written, so that should be correct.
Is that in the separate pediatric difficulty breathing, or is it under difficulty breathing?
Pediatric.
Okay, all right, so yeah, just be aware of that. And again, the only worst thing it's gonna do is they're not gonna take a nap, probably. I mean, that, like I said, it really gets kids. All right, any questions about albuterol, CPAP, anything of the sort? All right. I got just real quick, if this works like it didn't yesterday, so I'm not going to make any promises, but I'm going to try to run a video real quick. And what this is, it's just an example, because like I said, some people struggle with, if I tell you there's a certain breath sound, like, yeah, what does that mean? So real quick, I'm going to run this. It's just about 2 minutes. It gives you an audio example, albeit not a really great one, but an audio example of all these different breath sounds that you might find or have to document on your patient report.
Sounds, as well as a lecture and skills.
Do you have audio down there?
Part of this series. So let's get started.
That's a bad sound. We're done to cheat.
Okay, thank you so much for watching. Remember, you can go to our channel to find more.
Okay.
Thank you, ma'am.
You do, y'all.
All right, then, everybody, appreciate it. Okay. So, let me do this. All right. So, just real quick, that YouTube channel I have up, you guys try to go, and I think if it works the way I believe it's going to work, you subscribe to that. Whenever I upload videos, you'll get a notification. So if you need more time, you need to get some EMS hours or whatnot, you can go do that. As far as audit review, those are on hold due to everything going on. So what I would actually encourage you guys to do is don't completely negate audit and reviews. There's no reason why the battalions, or for you guys, Lynn, maybe Lynn, you could help me out. Actually, if you want to pull, 4 or 5 run reports from each shift and even get those to me, we can do audit and review on our own. We do not have to have the doctor or EMS director here for those to qualify. So I don't want guys to be ready for to renew their EMS certs in a few months and be like, ooh, I only got 2 audit and reviews because they quit doing them. We can do in-house or on shift level audit and reviews. We just, for my own benefit, document those for me in ERS, because I have a hard copy of our state EMS renewal form, and I've got dates on every skill we've done, every topic we've covered. So not only is it in ERS, but I have a hard copy of everything from January 2020 till now. If you need your EMS hours, I can help you verify those. But my point on that is we should do audit reviews anyway to see that we're doing good documentation. So work on that as a shift, but if you want my help, that's fine. I mean, pull a couple run reports, find good ones, find not so good ones, and not beat people up. That's not the point of it, but show and find areas for improvement on the documentation. Or if you have just a glaring example of the perfect run report, share that with people so they can see what a good one looks like. So we can do that on our own at the shift level. Let me stop the recording.